Hi, first of all, it's a pleasure for us to, and an honor actually to be here today with you to present at the HRC3 conference. I'm Vincent Lavoie, a second-year pediatric muscology fellow, and I'm with the Sundus NoorSaeed, a second-year pediatric allergy and immunology fellow. And today we'll present a clinical case about splenic dysfunction in an infant with PCD and polysplenia. We hope to stimulate discussion about certain issues related to heterotaxy with this case. So let's start off with the clinical case. So this is a case of a 31-year-old female with her first pregnancy, an unremarkable pregnancy until the discovery of a situs inversus totalis on the obstetrical ultrasound at 20 weeks gestational age. The lady then underwent amniocentesis, which revealed to have a normal karyotype as well as a normal QF-PCR. These tests serve to detect the most frequent chromosomal alterations. However, the couple met the geneticist a few weeks later to complete the investigation about the situs inversus totalis, and they did the heterotaxy, situs inversus totalis, and carcinogenic gene panel, and found that the fetus had a heterozygous variance in CCDC40, which is a genetically proven mutation for primary ciliary dyskinesia. In fact, CCDC40 is associated with a worse long-term respiratory disease, and it is also associated with organ laterality defects in PCD, but significantly less complex cardiovascular defects. So finally, the mother gave birth to a boy at 38 weeks. Right after birth, he was admitted to the NICU for tachypnea and desaturation, requiring high-flow nasal cannula. And the course of his NICU was also remarkable for transient right upper lobe atelectasis, which is pretty typical for PCD. The high-flow nasal cannula was weaned around 10 days of life. As part of the laterality defect investigation, the kid had a chest X-ray, which showed dextrocardia with right aortic arch, an echocardiogram showing atrial situs inversus, but otherwise normal intracardiac anatomy and connection, and the abnormal ultrasound was normal outside of the situs inversus totalis. There was only one spleen on the right side. There was no CT scan or other cross-sectional imaging, and the kid was discharged on supplemental O2 and inhaled hypertonic saline, as well as chest physiotherapy. The outpatient course was not really remarkable. He received the regular vaccination as well as the palivizumab. The supplemental oxygen was weaned around 2 months of age, and he only had one acute otitis media. The regular follow-ups with respirology was unremarkable. However, at 10 months of age, the family presented at an emergency room for 10 days of profuse diarrhea and fever, and the boy subsequently developed lethargy 24 hours prior to the consultation. He was then admitted to a tertiary center, put on IV antibiotics for a presumed refractory septic shock and cardiogenic shock. In 24 hours, the kid was intubated and ventilated due to respiratory insufficiency and had signs of severe organ dysfunction with coagulopathy and hepatic dysfunction. The PICU course, during the PICU course, the blood culture grew Streptococcus pneumoniae, confirming the pneumococcus refractory septic shock. The repeat echocardiogram showed cardiac situs inversus, severe left ventricular systolic dysfunction, and the repeat abdominal ultrasound in acute setting showed 2 small foci on the right adjacent to the large spleen, so likely polysplenia. Unfortunately, in 48 hours, the patient deceased due to strep pneumosepsis, refractory septic shock, and multi-organ failure. And the autopsy confirmed the presence of polysplenia with complete situs inversus totalis. So that brings us to some clinical questions, and we'll try to answer these by the end of the presentation. The first clinical question we had is, did this child have functional asplenia leading to lethal infection with an encapsulated organism? To answer this question, unfortunately, still remains unclear as we cannot assess the function post-mortem. However, we found two studies showing that there might be a correlation between polysthenia and asplenic, functional asplenia, as 47% of heterotaxy with bacteremia had polysthenia, and 12% heterotaxy with polysthenia have all jolly bodies, which are indirect clues of functional asplenia. Again, these are two small studies, so these are not robust data, but at least it gives an idea that polysthenia can be related to functional asplenia. By looking at our own clinical cases, we found a similar case of a term baby girl who had an older brother with suspected PCD but not confirmed, with chronic ear, sinus, and lung infection. The girl at day of life 2 presented with wet cough, nasal secretion, and desaturation, and then PCD was confirmed with 2 variants in IDIN gene. The cardiac echo was normal, the abdominal ultrasound showed multiple small spleens, and the scintigraphy showed no tracer uptake by spleen, confirming the functional asplenia. The second clinical question is abdominal ultrasound adequate for splenic anomalies in babies with diseases causing organ lateral T defects? Actually, current suggestion for lateral T defect screening in PCD coming from 2022 suggest to do chest radiography, echocardiography, and abdominal imaging, prioritizing the abdominal ultrasound for kids. The current suggestion, even if these are old, for lateral T defect screening in heterotaxy, suggest that for infant and children, abdominal ultrasound is a reasonable modality to assess splenic anatomy. And if there is an inadequate visualization by ultrasound, compute tomography is an alternative. So, by looking at our case, I think the take-home message from our local perspective would be that every baby should have heterotaxy, because we missed the first polysthenia and the first abdominal ultrasound. And I think to have a good conversation with your local radiologist is key to emphasize on what to look for specifically in kids with heterotaxy and PCD. Abdominal ultrasound is a reasonable first choice, but if there's any doubt or inadequate visualization, we would strongly consider to go with cross-sectional imaging. So now I'll hand to my colleague.
Thank you, Vincent. And now to move to the second part of this talk, why is the spleen important? So the spleen plays an important role in the development of the immune system and continuing providing protection through life. So also it's considered one of the largest secondary lymphoid organ in our body. Without spleen, we cannot do phagocytosis, and we need a functioning spleen to develop antibodies to capsular antigen, and these antibodies can coat opsonized encapsulated bacteria, allowing for their phagocytosis. Furthermore, the splenic phagocyte responsible for blocking the pathogen dissemination. So lack of this early defense barrier can explain increased susceptibility and rapid development of lethal sepsis in asplenia. And those patients are higher risk for encapsulated microorganisms like Neisseria meningitidis or streptococcal pneumonia like our patient. So after confirming the presence of splenic tissue, we need now to confirm the functionality of this tissue. So first, we can use the ultrasound, MRI, CT scan, any of the images to confirm the presence of the tissue. But for the functionality, we need more tests. So we can use radiology, hematologic, and immunological modalities, and all together to screen and to confirm the functionality. For radiology, we use technetium scan to measure the uptake of radiolabeled particles by spleen related to the liver. However, this modality not available in each center, and it's costly and carries radiation risk. So we need to look for more screening tool, simple, accessible, and free of radiation. The second part, we can use hematology, looking for the CBC and the blood film. So it can give us a lot of information looking for thrombocytosis, lymphocytosis, and monocytosis. This all non-specific, but can give us a clue for the functionality of spleen. Whole jolly bodies is a sensitive, but also it's not specific. And sometimes we have a delayed appearance like in newborn, and also it's operator dependent. Lastly, in the hematologic, we can look for the percentage of pitted erythrocyte. And this is a very optimistic tool. It's rapid and expensive and non-invasive. And normally we can see up to 4% of pitted erythrocyte in each individual, but more than 4 can be associated with hyposplenism. We have a couple of studies done in this context, asplenia and sickle cell patient, and they found pitted erythrocyte percentage 15 up to 70%. Lastly, we can use the immunological assessment to look for immune response after vaccination, and this can assess the functionality of the B cell. And in patient with diminished splenic function, we can see low memory B cell. So in summary, how we can determine the splenic function, we can use the percentage of pitted erythrocyte and whole jolly bodies as a screening tool for potential patient with hyposplenism. And then we can confirm by technetium scan. This is the only confirmatory method we have until now. So what's the goal from all this? The primary goal in all asplenic patient to provide adequate preventive medicine. So through vaccinations and prophylactic antibiotic and family education. So for vaccinations, the CDC recommend to give all the routine inactivated vaccines for those patients, and a supplementary vaccine should be given also Haemophilus influenza, meningococcal quadrivalent conjugate, pneumococcal, and influenza vaccine. Prophylactic antibiotic, each patient diagnosed with a functional asplenia should start on penicillin at least in the first 5 years of life. However, if the patient had any history of invasive pneumococcal disease, prophylactic antibiotic should extend it maybe through the life. For adults, we should provide them with antibiotic to be readily available if they have any signs of infections. We should focus on education and awareness for the patients and their parents for signs and symptoms of infections and when they have to seek medical attention. And we should provide them a medical alert card and bracelet for management in case of emergency, and regular medical follow-up to monitor the complication and adjust management is needed. So this is the end of our presentation. I would like to thank my colleague Vincent and Dr. Adam Shapiro and Dr. Bruce Mazer, both are professor at McGill University Health Center. These are our references, and thank you.